Opium has been used for pain management since 3000 BC, and its key component morphine is still considered a gold standard analgesic today. Apart from its pain-relieving activity, morphine has also shown to be highly addictive by its action on intrinsic reward systems. From an evolutionary perspective, an animal's survival relies on engaging in beneficial behaviors such as procuring food, mating, and avoiding predators over non-beneficial behaviors. As a result, animals have evolved to associate a rewarding feeling with outcomes that are beneficial via a phenomenon known as positive reinforcement. Experimental evidence points to dopamine release in the mesolimbic system as a central structure of our reward circuitry. Interestingly, opioid peptides and receptors are highly expressed throughout this system. They have also previously shown to participate in the modulation of physiological functions such as the descending pain pathways, equilibration of food metabolism, cardiovascular system regulation, behavior, and, more recently, in addiction. Addiction is a three-stage neurobiological disease resulting from an array of genetic, psychosocial, and environmental factors. The disease manifests as cravings, impaired control of drug use despite harm, and cycles of relapse and remission. In Canada, an estimated 21% of the population will meet the addiction criteria over the course of their lifetime. Additionally, addiction often presents with comorbidities such as depression, antisocial behavior, reduced life expectancy, and suicide. Therefore, it is considered a serious matter of public health. Opioid receptors have been implicated either directly by substrates such as morphine or heroin, or indirectly by substrates such as ethanol, cannabinoids, or nicotine in many addiction-forming pathways. However, the complete system has yet to be elucidated. Opioid receptors are GPCRs that are classified as mu, delta, kappa, or non-opioid nociceptin. Following activation by endogenous neuropeptides, the GI protein dissociates into G-alpha and G-beta gamma subunits. Free G-alpha inhibits adenylyl cyclase, decreasing cyclic AMP production, and thus inhibiting pKa. Similarly, the G-beta gamma subunit binds to calcium channels, reducing the influx of calcium, as well as potassium channels to increase the efflux of potassium. Acute activation of this pathway works synergistically pre- and postsynaptically to hyperpolarized neurons, inhibiting tonic neuronal activity. Chronic activation of the opioid pathway, seen in addiction, induces phosphorylation of the opioid receptor carboxy-terminal domain. Phosphorylated opioid receptors recruit arrestins to mediate pathways to desensitize, internalize, and traffic the opioid receptors, resulting in an unhealthy dysfunction of the reward circuitry. Because of these events, many studies have investigated the ability of the opioid receptor antagonists to inhibit or even reverse the addiction-forming circuits.
Naltrexone, for example, is a mu-opioid receptor antagonist that's currently FDA approved for treating alcoholism and opioid addiction with moderate efficacy in clinical trials. A meta-analysis from 2016 compiled double-blind placebo-controlled studies on naltrexone use for alcoholism and opioid addiction and found that previous addicts were less likely to relapse following several weeks to months of naltrexone treatment versus the placebo group. In the alcohol abuse studies, lower cravings and less heavy drinking days were also noted for the naltrexone groups. This leads us to ask the question, could naltrexone also have uses in behavioral addictions like pathological gambling? Well, in another double-blind placebo-controlled study, researchers looked at the use of naltrexone to curb the urge to gamble in patients with a gambling addiction. For patients that completed the trial, 75% of the naltrexone group showed improvement, whereas only 24% of the placebo group showed improvement. These studies highlight naltrexone as a promising drug for treating both substance and behavioral addictions. Unfortunately, for every paper with positive results, there's another showing naltrexone having little to no effect. In another article on naltrexone treatment for pathological gambling, researchers found no significant reduction in the urge to gamble relative to the control. The major difference between the two was the dosing. This brings up another problem. Among most of these studies, there's no consistent dose of naltrexone given, which makes comparing results quite difficult. Other major limitations of these studies include small sample size and high dropout rates. Lastly, several studies reported high liver enzyme levels and potential drug-drug interactions, specifically with non-steroidal analgesics. In conclusion, naltrexone has some reliability for substance abuse addictions. However, for pathological gambling, the result remains inconclusive. More research must be done in order to standardize addiction diagnosis and dosing in order to rectify the inconsistencies between studies before a proper conclusion can be made about naltrexone. Until then, we must continue to search for pharmacotherapies for addiction and look for synergy with current pharmacotherapies. With the right questions in mind, we hope to find an effective treatment for addiction.